Hello, and welcome to the Workforce Wellbeing Through Coherent Breathing webinar presented by Healthcare Excellence Canada and Translating Research in Elder Care, or TREC. My name is Neil Dreimer. I work as the Director of the Health Innovation Programs at HEC. My pronouns are he and him, and I'm so pleased to be joining you today as the host for today's webinar. I want to begin by mentioning that HEC honors the traditional territories upon which our staff and partners live, work, and play. We recognize that the standard of living that we enjoy today is the result of the stewardship and sacrifices of the original inhabitants of these territories. We must commit to not repeat past mistakes and to work towards more equitable and respectful relationships with First Nations, Inuit, and Métis. Acknowledging the territories and the original stewards of these lands is a fundamental responsibility of our organization and part of our commitment to work towards truth and reconciliation. I also want to acknowledge that I'm joining you today from Ottawa, specifically the River House, which is on the water, and it's on the traditional unceded and unsurrendered territory of the Algonquin people. We recognize and deeply appreciate their historic connection to this place and the opportunity to gather here today. I also invite you, if you haven't already done so, to share who you are and where you're joining from in the chat box at the bottom of your screen. I also wanted to let you know that we are pleased to offer French simultaneous interpretation for this session. If you wish to hear the voice of the interpreter, please select French from the interpretation menu at the bottom of your screen. We invite you to share your questions and comments at any point throughout the webinar in either of our official languages. If you have a comment or a question, please add it to the chat box. We will look to address as many of your questions as we can during the Q&A session towards the latter portion of today's webinar. And I also wanted to let you know that if you do need any technical support at any point throughout the webinar, you can reach out to our tech support using the chat feature. This session is being recorded and will be available on our website in the next couple of days to review and share with your colleagues who may have missed it. So with that, I am so excited, and it's always a pleasure to welcome our speaker, Dr. Carol Estabrooks, who will discuss the Coherent Breathing Toolkit created to support well-being in the long-term care workforce. Dr. Estabrooks is a health services researcher and holds a Canada Research Chair in Knowledge Translation in the care of older adults in long-term care settings. She is scientific director of the Pan-Canadian Longitudinal Research Program, Translating Research in Elder Care, or TREC, as you might know it. Carol has been the recipient of several awards and distinctions, including the Order of Canada and the Betty Havens Prize for Knowledge Translation in Aging. She is a fellow of the Royal Society of Canada, the Canadian Academy of Health Sciences, the American Academy of Nurses, and the Canadian Academy of Nurses. So with that, I just want to remind you to please feel free to drop any questions or comments you have throughout the presentation, and I'll now pass it over to Carol.
Great, thanks, Neil. Thanks everyone for making the time to come today. I'm hoping everybody can see the slides all right, and I'm gonna have to ask for them to be advanced today. So let's go to the next slide. I'm seeing two, but I think I'm just seeing the English and the French. Okay, I can adjust and cope. So I'm going to do two things today. I'm going to do a very brief background, and I'll spend most of the time on bullets 3 and 4. But just so that contextualize, because we did a webinar on the findings, it must be a year and a half ago, but many of you may not have heard that, or you've forgotten you were at it or whatever. So I'll do a little bit of context setting, but I want to spend most of the time talking about the toolkit and the virtues and shortcomings of toolkits, and a little bit about individual versus organizational strategies. Next slide. So this is part of our large program where been going, I guess, coming on to 20 years now, where we're trying to contribute to positive system change by developing some practical solutions for improvements in the quality areas. And this breathing project I'm going to talk to you about today is in the quality of work life for staff area of the quality dimensions, but only so because it's also in the service of helping staff be better equipped to provide quality care to residents. Next slide. Next slide. So this is the thumbnail sketch, super high level overview of the study on this little chart. We did a study, a simple pre-post study over 8 weeks. We did baseline measures before and post-intervention measures afterward. And all during that 8 weeks, we did a lot of what we call process evaluation, which helps us understand how is it working, what are the barriers, what's facilitating it, why are people dropping out if they are they making adaptations, which is something we were really interested in. So this was called the Coherent Breathing Study. Well, it had a much longer, fancier name, but we call it the Breathing Study for short. Now, breathing has been used for millennia by various kinds of practitioners, regulated and non-regulated. There's nothing extraordinary about it. However, if you just breathe, it's quite useful because it keeps us alive, but you need to apply some different strategies to your breathing patterns to get some of the benefits I'll talk about. There are probably a dozen different breathing techniques. We picked one that we knew had some evidence because most of them, although well used and well incorporated, and we know they work, haven't got much evidence, research evidence behind them. So what is this not? This was not a mindfulness study. This was not a meditation study. This was a simple breathing study. Now, breathing is a part of all of those practices, but we wanted to just isolate the actual breathing part and really be practical about it. If people are uncomfortable with meditation or mindfulness or think it takes too long, we didn't want to clutter things with those other broader approaches, which can be very helpful for people. Coherent breathing is a little bit different than some of the yogi and other kinds of breathing. It's a simple, slow in for 4, 5, or 6 breaths, whatever comfortable. It's a low and slow, deep in breath, no pause, and the same 4, 5, or 6 count on the out breath. So there's no pause between the in and the out breath. We started people at about 2 minutes a day, 1 to 2 minutes, because sometimes if you start with 10 minutes a day all at once, it can be, sorry, I'm smiling because of some of the process evaluation data we had and some of the misinterpretations because our instructions weren't really clear at the beginning, but I won't go there. So we gradually asked people to work up from 2 or 3 minutes a day to 8 to 10 minutes a day over an 8-week period. What we found was by week 5, they had internalized the process and were beginning to do all kinds of other things besides just breathe with it. How do I know that? Because bless everybody's hearts, they kept diaries, not big, long, epistles of journals, but little tiny short bulleted notes. Maybe they'd make 2 or 3 tiny scratches a day, but it was enough for us to get a really comprehensive view of how they were experiencing it and what they were doing with it as they began to internalize and adapt. Next slide. So we had 30 homes, and when we started, there were over 600 people who were recruited. Of those, about 350 started the session, and 250 did the whole 9 yards. Now, why was there such dropout? We have been asked by the government to do a study in 2021 and 22 on how COVID was affecting people. And we were beginning to see really, really, really troubling things in both our interview data and our quantitative numerical data. And we were beginning to talk to the government about what we were finding because they were really interested in what they could possibly do. So we saw increases in anxiety, and we saw increases in insomnia and depression, and quite high levels of positive screening for PTSD and things like this. So the government said, well, can you now do something? Well, it was the middle of the COVID pandemic, and we couldn't get into homes, and we didn't have any money. And the government said, well, we haven't got any more right now. So what we did is we worked with HEC and AHS, and there was a grant that came to Alberta, and a piece of it came to us to do this breathing intervention. So we changed all of our processes and all of our data collection strategies and all of our intervention strategies and put the whole thing up online in a really short period of time. That was what was hard for us. What was incredibly difficult for the participants was that they were in the middle of outbreaks. They were right in the very thick of COVID. There was short staffing and all the things you all remember. And in some cases are still going on, in many cases actually. So the dropout rate was not surprising. That's why we'd enrolled so aggressively to begin with, and why we kept really good records as we went to try and understand. And so most people dropped out because of competing demands or lack of time or just inability to balance their workforce demands, which was understandable. Next slide. 250 though was still a good number to do the kind of work we wanted to do. So I won't go into this in detail because it's a bit I don't like tables a lot. I prefer figures. So I look at these tables and just think, oh, what does all that mean? All this means, what is this is here to say, is that this is the table we put in the main publication, the scientific publication that said all of the things we measured, except compassion satisfaction, changed in the direction we wanted at statistically significant levels, which only means that we're confident they didn't change by chance. They weren't random changes. And so you can see the things we assessed on the left: anxiety and depression, insomnia, which we're doing more work on now, by the way. It's quite a significant challenge for all health workers, stress and burnout. So that was the main quantitative finding of the study. I keep looking over here because I'm looking for the next slide, but that's okay. It's not here. Let's go to the next slide. These are just 3 or 4 slides that present exactly the same thing, but just in visually a little bit different way, if you like different visuals. These are not as complicated as they look. The top 3 bars are care aides, nurses, and managers, and that's before they did the breathing. And the bottom 3 are the same 3 groups after they did the breathing. So what we wanted to see here, and what the significance levels suggest, is we want to reduce the amount of red, because that's the people in high risk categories with, based on previous research, what would be considered high and critically high levels of stress, for example. So you can see that what you want is more blue and less red. And you've got that generally across all 3 groups, most notably in the managers in this case. And the next 3 slides are the same thing, only different concepts. So this is anxiety. We had the same pattern. This is depression, same pattern. And this is burnout. And I'm going to come back to this one, not this slide, but to burnout a little bit later on, because one of the things that we understand now about burnout is that there's general agreement that it's thought to be largely a factor of the work environment, and most strategies to work on burnout that are successful are organizational in nature, not individual. And I'm going to come back several times to individual versus, but again, we saw the same pattern here. So that was the study. Next slide. And this is the process evaluation that we did. So I'm going to read a couple of these. These were about adaptations. And this started to happen around week 5. During work, before work, after I got home, prior to going to bed, anything at work and anything that happened or anything with some of the residents, I used the breathing just to back up and take 5 minutes. And then the other one is an example of a care aide who was taking her NCLEX exam, who had test anxiety, who thought, well, I'll try and use it before I take the exam. And she perceived that she felt much less stressed. and she passed the exam. So she credited breathing with that. That probably wasn't the entire reason. So why would they be finding these things and making these adaptations? Breathing works because it activates the parasympathetic branch of your autonomic nervous system. That's the relax, slow down, digest, rest branch. That's the branch that makes you feel calm. And it downregulates the sympathetic system, the fight and flight response. So the feelings you get aren't just in your mind, they're actually bodily feelings. You're changing the balance. So you're down-regulating the sympathetic and up-regulating the parasympathetic. And that's why, because those changes happen physiologically, that when you're in a room with a resident and you are calm and grounded and breathing, even if the resident is nonverbal and has quite significant dementia, as long as they're not in an extremely agitated state, sometimes even then it will work, they can co-regulate with you just the way a little baby uses its mother's nervous system to co-regulate. That's a big part of the whole attachment business. So it's not magic, it's not voodoo. If you go into a room of upset people in a meeting and you're really good at this and you can ground yourself and just sit and watch other people, people around you will begin to calm down. You have to be good at it, and you have to sometimes do that for 4, 5, 6 minutes. I've seen people who are very good at this, where it just comes naturally. Just help bring the temperature down a little bit. So we started before COVID ever happened thinking about how could we help residents who were really agitated, especially those who might be doubly agitated from the organic changes that cause responsive behaviors of dementia and recurring or reactivated PTSD from past trauma, for example, in soldiers, but not just soldiers. There's been a lot of research done on Holocaust survivors and veterans, and we know a lot about them in long-term care homes, but hardly anything done on what you would call well, I don't know if it's fair to say regular, but the rest of the population. They probably have as much PTSD symptoms as the general population does, maybe a bit more, because sometimes there's differential admission to a long-term care home. And in the general population, it runs 9 or 10%. That's just PTSD. That's not trauma. Trauma rates are dramatically higher than that. But not everybody who has a traumatic experience goes on to develop unmanageable PTSD. It's a minority of people. That doesn't mean they don't have other symptoms and don't suffer. So we started out thinking about residents, and then COVID happened and that went off the rails. And then this started to happen, and we thought, oh, excellent. I thought it would take 1 or 2 more strategies and studies to get to the point where the care aides and others were using it in this way. So we were very excited about this. Next slide. And then there were other things that they did. They just talked about positive effects. If you're calm, they're calm. I try to calm myself down, and that helps the residents. Or the skeptics among them, which there were many. I didn't expect to have a good improvement breathing. In fact, your stress levels will go down and you'll be able to focus more. So I really like this one because increased focus is a result of having a more balanced sympathetic parasympathetic arrangement going on. Next slide. And then I was very excited about this one. So we were just doing the breathing study and doing measurements. We weren't talking to them about, you should go out and proselytize about this. But they started trying to spread it themselves. We talked about incorporating into our debriefing sessions when we have a code, an altercation, etc. And in order to get everybody's levels down, stress levels, we start the debrief with a coherent breathing session. And I'll show you, talk a little bit more about that. It's extremely important because I think a lot of the time we're just holding so much stress, and you could use the breathing technique. So I've been sharing it with people all the time. I talk to them all the time about it. So this is classic results of having an intervention that has a lot of the features of Everett Rogers' recommendations. People can see the results. It's easy to do. It gives them a relative advantage over what they were doing. There's a bunch of features that this strategy had that make it more likely that these things will happen. Next slide. So in summary, better sleep, more relaxation. They talked in the interviews about improved interactions, improved stress and anxiety. Their physical health scores improved, which was interesting, and the ability to use it in multiple situations. Next slide. So you go to our website, trecresearch.ca, the URL is up at the top. You will get this page, and depending on whether you use a phone or a desktop, because we built the toolkit for the phone, you will see that little more thing where the red arrow is. And if you click that, you find the breathing toolkit. And if you're on an iPhone, the breathing toolkit words are up there on the right. It's just a tab. And then you'll go to this page. And if you click access it, you'll get here. So yeah, okay. So let's not go past this till I say, because I have a couple things to say. So I want to say something about toolkits. We know from decades and decades of work that toolkits and guidelines and dashboards all by themselves do not work. They just don't change human behavior. But if they're facilitated and or coached or supported, or whatever word you choose, we use the word facilitation a lot because we study it, then toolkits become what they're meant to be, tools to help with the process that's mediated with other people. So we build a toolkit, and this is the first toolkit we've ever built because I have a real thing about building things that don't change anything. But it just seems so logical here, and we wanted to get it out, and we wanted a tool that we could use in this province where we're doing a bunch of work on trauma-informed care and other things to be able to work with. And then when we started talking to managers, we thought, oh, this is a tool they could use. So this is a toolkit. It's not anything more. And if all you do is send it up to all your staff, probably not much will happen. And it only takes a little bit of facilitation if you want to use it as an organizational strategy. Next slide. So I was going to do some videos, but we thought that was too risky to be flipping back and forth. And I was fine with low risk. So these are just some screenshots of what's under those tabs. So the top, this is just the introduction. And you can explore more tabs. And it's very intuitive when you get to it. Next slide. So these are all on different pages when you click. So we've discovered over many years that the staff in long-term care like a number of things. Two of them are infographics and little short 2-minute videos. And they like animated videos, and those are less expensive for us to produce, and we can do them faster. So these two at the top are about introducing the idea and why you might want to consider it, and then a little bit about how it works, just very super basic stuff about what I just said, upregulating your calming system and downregulating your fight and flight system, and how that also improves not just your sense of stress and anxiety, but it improves heart rate variability. Practiced regularly, there's really strong evidence that this improves heart rate variability, and heart rate variability is strongly associated with cardiac health. Poor heart rate variability is associated with premature cardiac death and all kinds of things. So it's a really good thing to have. We didn't start out because we thought everybody should have better heart rate variability, which of course we all should, but that is a clear and often the main thing that's studied with coherent breathing. And then there's a step-by-step video that's 4 minutes long on how to breathe. There's two, because when we field tested this with carries, they said, well, this one's got that woman talking about how to breathe and it's distracting. So you can have the woman doing a count in and out for you, or you can have it just with the visuals and the music in the background. And that's the one they use. Some of them tell us that they use the most. Next slide. They also like infographics. So these are just, I think there's one more later, but these are just two infographics what the breathing study is, basic steps, 1, 2, 3, and they can print these if they want and share them. And then one on benefits. We have had a lot of success when we do big feedback sessions after our major data collections. We do a lot of tailored feedback reports and webinars and stuff. But when we go to the front line and we do short sessions and we use these visuals and they find them really helpful, which is nice because it can be really challenging to put research into language that a normal human being can understand. And this forces us to do that. And then it turns out it's useful for all sorts of other people too, not just people and busy people on the front line. So those are two examples. And the next slide is how participants made coherent breathing work for them, the kind of adaptations they did, the fact that it can be practiced anywhere, anytime, and practiced in any situation. And nobody has to know you're doing it. It's not like you stand up and heave and ho. It can be very quiet. We had two groups in our study. One just did plain breathing, and one did breathing with a biofeedback device from HeartMath. And they had equally good numerical outcomes, like on stress and anxiety, but the group without the device found it much easier and less cumbersome and troublesome. We had a lot of technical issues with the biofeedback device, so we were really pleased with that. The research suggested you might get a bump by using biofeedback, but it didn't work for this crew. They were very clear. No, just leave that part out of it. So this is just some basic information about how it can be adapted. Next slide. This is more for people like managers who might be interested in some strategies. One of them, well, the one on the left is for everybody. The reason we did, it's like tips to practice coherent breathing because it's trying to address some of the barriers they're entering. The biggest barrier they told us about, they couldn't find a place to do it at work. So they would often go to the bathroom and lock the door so they could have 4 or 5 minutes by themselves. And they talked about if we just had a room, not a noisy room, not a room where people can interrupt, not a room full of wheelchairs and lifts, just a little quiet room. I akin that to when I was working clinically and in hospitals where they had, often we'd have a chapel, that kind of quiet space to just reground yourself. It doesn't, if they said it can be quite modest, it can be small, just quiet and pleasant. That's may seem like a big barrier, but it's actually in the great scheme of what things can cost and the effort required, potentially a very doable thing for many homes. So there's tips in it about managing your time, finding a quiet place, because they all said we haven't got time. The Carrieds in particular have such complex lives, so we tried to help them with some of the tips others had given about how to make the time and how places that you could practice it where you wouldn't think you had time, but nobody has to know you're doing it. Then there's a facilitation guide, which is it's good for anybody, but anybody could use it, including a curator, a nurse, or a LPN, or a physio. But we oriented this to try and give managers and DOCs just some ideas about how to incorporate it as a facility or a unit strategy. And so this is part of our attempt to try and build in things to the cool toolkit that suggests that if you facilitate it, it'll be much more successful and the staff get really important benefits. Now, breathing does not address the structural problems in any workplace, but that doesn't mean it's a bad thing. It's okay to have an individual strategy that works. And if you can bump something like this to be a bit of an organizational strategy, you're still not fixing the structural problems. What do I mean by that? It doesn't fix the short staffing. It doesn't fix the lack of resources. It doesn't fix increasingly demanding and complex residents. It doesn't fix overuse of agency staff. It doesn't fix racism. It doesn't fix microaggressions. Those take much more comprehensive strategies, but it still works despite all that. So I'm very enthusiastic about it individually, but also trying to nudge it toward a more organizational strategy. Next slide. So this is what I've just talked about. Most of the problems, many of the problems we see, that's more fair, especially burnout, are structural in nature. Um, Anxiety and depression are more complex. People bring certain predispositions or conditions with them. Work can exacerbate them or keep them steady or even lower them in some cases. And if you're into, like Alberta is right now, trauma-informed care, like we're doing a big policy forum this fall, and we'll be doing implementation strategies next year. The things that help you create a trauma-informed work environment are the same things that contribute to quality of life and quality of work life and person-centered care and are beginning to help address these structural issues. So all this stuff is not, it's all part of the same bolt of cloth. And I suppose if person-centered care was perfect in all situations, we might not need some of the things, but we do. And COVID, I think it reduced the stigma around trauma and is helping us open up more conversations without getting crazy because we don't want it to seem like a burden to an organization. But the new standards, I think I counted and I think they mentioned trauma-informed care 52 times. And there's some specific criteria about it. So there's a big emphasis on it. But nothing about trauma-informed care is different than a healthy work environment that's safe and that supports people, basically. Next slide. And this is just a model we use quite a bit especially when we're talking about burnout. It's very simple. It's very straightforward. We all understand it. When your demands exceed your resources, is when you create the conditions for burnout and other things. And demands don't have to just be physical. There are physical demands, there are psychological demands, there are emotional demands. So during COVID, as you all know better than I do, the emotional demand of taking care of isolated people who you knew were deteriorating because they were so isolated, whose families weren't there at the end of their life, was extreme. So that's an example of an emotional demand. So it's hard. I know it's hard because there's this incredibly complex workforce crisis going on across the country. And many jurisdictions are getting even more complex compositions of their frontline workforces. And that creates other stresses and strains. So it's not easy to balance that scale. But when our demands exceed resources, and especially if that imbalance is sustained, is when we start to see some of these things. Next slide. I can't show this because I was worried the video wouldn't work, but if you go to the website, this is a video we shot in one of the homes that adopted this as an organizational strategy. So it's real home, real DOC on the left there, and real care aides and educators and rec therapists, etc. We wanted to do something that was from the lived experience people, not us saying. And so it's a nice little video, and it talks about how they use it and why they think it works and why using it organizationally and having the manager involved helped many of them to feel like they were heard and as important as others. So have a look at that if you want. It's a really nice little video. It takes 4 minutes, 3 or 4 minutes. Next slide. That's all my slides, and I would like nothing better than to have some Q&A or however we're going to do the discussion as we go forward. So thank you very much for being so attentive and open to any comments or questions. Turn it back to you, Neil.
Thanks so much, Carol. And just thank you for once again sharing all the great work that TREC did to support the breathing toolkit, both on the research side, but also on the implementation side. So, as we mentioned in the chat, please feel free to chat in your questions for Carol, and maybe I can start off. And I know obviously we've had a few conversations over the last couple of years about the toolkit, but I'm wondering if you could share both from the research findings and the actual implementation, anything that might have surprised you about what you saw?
The biggest surprise to me was how quickly, once they developed the habit and internalized it, that they started just doing all kinds of things that we didn't anticipate. That was probably the most exciting finding I saw, because we know that if people are going to implement, they have to be able to adapt. But researchers get really anxious about adaptation sometimes because, well, if you're adapting it, then it's not the thing that I tested so beautifully anymore. Um, but there's actually quite a bit of latitude for adaptation. There's kind of crazy adaptation, but they weren't really adapting the intervention. They were adapting the conditions under which they used it. And they were testing, well, what if I breathe with the resident who's upset? Will that help? And, breathing is a pretty benign thing. It's pretty low risk. I mean, you might hyperventilate, but, you're not going to hurt anybody by breathing calmly type thing. So, yeah, that was the piece that I was most excited about, interested in, because we did a lot of checking with them, was the care aides in particular, but the nurses too, who said, I just never stopped and thought. It was the questions that we were doing, the questionnaires. I never really thought about how all this COVID stuff might have affected me. So that was just an interesting side, that sometimes you worry, often you worry that your questions will be invasive and intrusive and upset people. But they seemed here, at least, to say, no, I didn't think about that before. So it helped them to reflect on the experience and to, I don't know, validate might be too strong a word, but that was interesting to me.
Thank you for sharing that. And so we've gotten a few questions and comments in the chat. Maybe one of the ones that we could start with is any plans to expand this beyond the long-term care sector? So, will you experiment? I think Suzanne Dick was asking, will you experiment in a hospital as well?
Our team probably wouldn't, but there's no reason, and it doesn't need to be, the study doesn't need repeating. It would be implementation that needs to be looked at and assessed. But there's no reason it shouldn't be. Absolutely. I mean, if everybody, I mean, I don't know if you could have overcome the catastrophe that was going on in ICUs during COVID, but it'll work for anybody, whether you're a cook or a nurse or you know, an accountant. And what I'm going to focus on, and it's not that I have anything against acute care, it's just that I would be excited if we could actually get it into all 220 or however many homes we have right now. In long-term care, I'm really committed to long-term care, and we've always worked only in long-term care because everybody, well, it's true, everybody forgets it. No, researchers don't want to research there. And it's easy to overlook. And I have found them, generally speaking, so welcoming in terms of, and it may be that they haven't had as much attention as they should have had, but I like working with them. So if I could get it, we're going to do an extra press after Christmas and really we're going out to do feedback on our last big project. So we're going to wrap the breathing toolkit right into it and really push it. And I keep talking to, there's a provincial group of DOCs that I'm going to go back and talk to again about it, because it's free and it's easy, and you haven't got 14 policy directives coming down from the government about it and all that kind of stuff.
Free and easy are always a good starting points. And we love the tangible and practical. Some other questions, again, lots of positive feedback in both official languages. Merci. I'm just going to read or translate. Olivier from Quebec said, thank you. He's going to share it with his managers and just talking about little actions um, with value, added value that has positive impacts on the workforce. So just a thank you there. I guess one of the more practical questions, and that you alluded to, and I'm just reading my notes here. So can you just speak again or remind where can you learn this breathing technique? And does the toolkit include step-by-step instructions on how to practice
Yep.
the breathing technique?
Yep. There's two or three ways we present step by step. And that video clip that you saw, not the clip, but the picture, the green picture, is one way. There's music and there's a woman walking you through it, but there's infographics and there's animated videos. So yes, you can learn it there. And we try and provide, I think we have some of it up yet. We're putting our reports of the study up too. We have one up and there's two more that'll go up soon. We have three kinds of reports that we did. And I wonder, there's a couple things I'd like to go to. Somebody asked a question about, was there discussion about moral distress? Not in those words, but people talk in ways that I would understand to be moral distress, which is often when a person's put in a situation of not being able to do what they know is needed or having to do something that hurts somebody or isn't needed. We didn't measure it, but we see it in all conversations that we have, especially during the worst lockdowns of COVID. That's when I think it was. So I didn't measure it, so I don't know if it fixed it. And I would doubt if breathing could help moral distress. It's a different process. It's cognitive and it's emotional and it's psychological, but it's a good question. I just wanted to make sure I hit that one.
Thank you. And I'm just trying to keep track here. There's lots of comments. And where was so was so Melissa was asking, was organizational readiness and capacity taken into account before sites were chosen to
Glad you
participate?
asked that. So the implementation people write thousands of things about organizational readiness, and I have colleagues on my team who've devoted years of their life to it. I am not, I don't, I believe it's a thing and it's an important thing. I'm not as big a fan of it because it's complex to measure, and I haven't seen as much evidence as I think we should have to say, well, you shouldn't do things where there isn't organizational readiness. It is true that if you have a coalition of the willing, it's a whole lot easier. So no, this was COVID conditions, remember, so it's purely voluntary. We just went out, Julie Melville, my field person, went out and just talked to everybody in our cohort and anybody outside our cohort she could find. And so it was voluntary. And so in a way, you could say they were ready when they signed up. Undoubtedly, it was a biased sample to some degree. But I have found, so if you know Roger's work, he's got a beautiful distribution of the kind of people that take things up and the diffusion curves overlaid on it. And there's the innovators at one extreme end and the laggards at the other extreme end. Nobody should waste time on the laggards because you could it's the 90-10 rule. We spend 90% of our time trying to bring 10% of the people along. If you can get the innovators and the early adopters, they will bring the early majority. And once you've hit that, which is about 35 or 40% of the people, it will then diffuse, even eventually sometimes to the laggards. So I'm very keen to get those early adopters involved. They're the really important group, but you can't get them without the innovators who are the kind of rebels up there who'll test stuff. And it's the early adopters who people really look at and say, well, if Kathy's doing that, it must have something good about it. So I'll try it too. And once you get that early majority part, then it has a life of its own if you're talking about diffusion. So I don't want to organizational readiness. It's an important factor, but there are different ways to approach it. And I've always favored, let's go after the welling. This is hard work. And then let's see what, because sometimes and if they're not moving past into the harder groups, like the late adopters, sometimes you need some other strategies that have more intensity to them. But if it's a good thing, if you've got a winner, you don't need to do much once you get those early groups engaged. If you've got something really painful, like, I don't know, implementing Connect Care in Alberta, you should do it a little bit differently.
Oh, thank you. Wise words on diffusion of innovations there. I'm just reading. Well, Cynthia Sinclair has put some quite a nice comment in the chat. I think COVID exacerbated an already stressful work and work life experience of long-term care. So any strategies that it can improve people's outlook, both physical and psychological well-being, are important are important and needed. As you say, the benefits are directly related back to the residents we care for. So, I mean, I think you said it well there. Any comments on that?
There's one, maybe two, Neil, one in particular. So I've talked a lot about, and we all often talk a lot about, if the managers and the DOCs, whatever their titles are in your jurisdiction, if we could just get them on board and they should do this and they should do that. During COVID, the most extreme adverse consequences, and we did a lot of surveying and we've just resurveyed the province, were among managers. They, to our surprise, not really, once we started thinking about it, the impact on them was more severe than any other group. And so that's just a reminder to say and so there's a huge effort right now to try and figure out how to focus on the managers. Anybody out there as a manager knows what it's like. You're squeezed from the side, you're squeezed from below, you're squeezed from above. The families are upset, the staff are upset, your operators want you to do magic. The province sends down 42 regulations every Friday afternoon during COVID, which has happened in a lot of places. So they're in this kind of vice grip, and they tell us they don't feel like they have autonomy and they don't feel valued. And it doesn't matter if you are valued, if you don't feel valued. So it's how do we communicate that? And then how do we work with people to help them understand they have maybe more span of control than they realize sometimes, or to work locally where they have a lot of control. So I just want to put a plug in because the only time in my life where I've given a webinar where everybody turned the camera off, and I thought, oh my God, what's going on? So I'm texting my field coordinator. So why is everybody turning their cameras off? Are they bored? Like, what's going on? She goes, no, Carol, they're crying. And it was a webinar showing the managers their data rate in probably 2022. And I felt really bad because I hadn't anticipated that, but it was about seeing that what they were feeling was real. So I think we have to pay a lot of attention because you can't run a hospital and you can't run a long-term care system if you haven't got good managers. And they tend to be slightly older women. They're almost all nurses, which is probably, in my opinion, biased opinion, why they are as durable as they are and as capable, because they're used to managing multiple things with few resources. But they also have choices in front of them around retirement. And Stats Canada just did a survey, and it's exactly congruent with some work we did. 20% of, generally speaking, staff across healthcare settings intend to leave in the next year. Well, if you lose a fifth of your workforce, it's all going to fall apart and we're going to be in a mess. So I think we're finding, and I've been talking to Deb Gordon and the Health Workforce Canada crew, anybody who'll listen, and when there's a lot of talk here, recruitment's a necessary but highly insufficient thing. We have to retain people. I mean, every nurse on this call, if they've been in the profession for 30 or 40 years, thinks, oh yeah, well, we've been saying that for 40 years and we haven't done anything. We have to change our work environments so that they support people so that we keep them, because it's so expensive when you have a high turnover. and it's not good for resident care, and it's not good for anybody. So I think retention is going to be the watchword of this decade, and we have to get a handle on it. And it's not easy to do, but it's not as hard as we all make it out to be sometimes. Um, there you go. That's my little sermon today about what we should do. Retention, which means healthy workplaces.
Absolutely. And I know that's a big focus of our efforts here at HEC as well. So
Mhm.
just wanted to share, and I don't have the full name, but somebody had mentioned that they started doing the breathing exercises during meetings with all staff, which was a great seller to support our residents. So lovely to hear real time feedback on that. I got another question, and this maybe wouldn't be the primary goal of this work, but you mentioned that this approach is not necessarily intended to address larger systemic concerns for the workforce, not surprisingly. But have you seen any evidence that having teams use this approach can impact their team culture, and anything around that?
Well, that's an interesting question. I have only got one example right now, but it's the one that we did the video on that's on the toolkit page, the in-home video. There's a funny thing that happens when the DOC, in that case, it was the DOC, gets engaged. And I think it's the same phenomena that happened during COVID when the care aide said, my manager doesn't know how to do care anymore. She would be a disaster. But you know what she did during the worst of it? She came out and rolled her sleeves up and she emptied garbage cans and she did everything she could to support us. And that made us feel like we could go on. So what's happening when that happens is I think something similar to what's happening when a manager or a DOC gets engaged and says, look, this is helping you guys. And if we do it as a group, it'll help us as a team. And I'm willing to do it with you. So yes, I think when an organization experiments with adopting it, maybe in small, not the whole organization is hard to start with, but like, when managers adopt it on their units and then those staff end up on other units sometimes. So I think it does something for teamwork. And it's not that it's a teamwork intervention, but you could probably do pottery together if you had the means and it would be helpful. So I think it's that process of creating the carries, I think they commented in the video too. It made us feel equal because they're at the bottom of a rigid hierarchy. They're a highly racialized group. We might sit in our offices and think there's no racism or microaggressions or bullying going on, but we'd be ill-advised to think that. It's hard to get people to talk about it because they're scared. But when you get there's actually a lot of microaggression going on and they don't feel equal. So if you can work at some of those core things, and I like practical things. I think it's really hard to walk into any environment and say, we are now going to fix morale and be a happy team. It's much easier to walk into a group and say, here's a little concrete thing. Let's try and do this together. It's not as threatening and it's not as hard and you don't have a pit in your stomach when you're trying to do it. So yeah, I think, but not because breathing builds teamwork. It's about the doing it together and the process of doing that. Well, I suppose it might build teamwork if everybody's nervous systems aren't all jacked up. That would help, but
But yeah, no, it's something, it sounds like something practical that starts like getting people to focus on something together. So thank you, Carol. And just again, I don't think we have any more specific questions, but lots of positive feedback.
please
Um,
go into the web page and look at the toolkit. You can download all the stuff on it. And, I'd love to hear back, or maybe you can tell Neil, I don't know, however, if you're trying it and using it, I think every story that people tell helps us learn another way to do it.
no, absolutely. And people can reach out to either the folks here on the call HEC or directly to
Yeah.
the TREC team. And we've put various links in the chat box, TREC, TREC, trekresearch.ca. And there's also a specific website link, trekbreathingtoolkit.com. So either of those, you'll have access to lots of resources. And please feel free to reach out to us if you have any additional questions. Thanks, Joanna, for putting the links there. So with that, I think we've run out of time, but I wanted to thank you, Carol, for this again amazing presentation, and great to see how many people have joined this call, even in the summer period. There's still summer left. We also want to thank the audience again for their excellent and engaging participation and discussion. So from on behalf of HEC, we just wanted to share an exciting announcement. We'll be launching a new awards-based program later this year to support person-centered care in long-term care homes across Canada through appropriate use of antipsychotics and innovative non-pharmacological interventions. So please sign up to our newsletter on our website or follow us on social media to learn more about how you can register. It should be launched hopefully in the next few months. And as well, we also would appreciate your feedback as always to let us know how you found this session. So you'll see some poll questions on the screen right now. We ask you to just take a few moments. And just of note, one of those questions about gender is specific. We collect that information because it's related to our funder Health Canada's requests. But again, all of these questions are optional. So with that, after you complete the poll, we'll say thank you. This concludes today's event. And again, really appreciate you participating. Thanks to Carol and the team at TREC. And have a lovely day. Thanks so much.
Thanks, everybody.